welcome back to Reproductive once again. We're almost done with embryo. I thought the last video was going to be the final embryology video, but my personal embryology section is a little longer because of all the Kaplan stuff I've introduced into my annotated first aid. So this video will actually be the final video for embryology. So give me a second while I post it on the Facebook page real quick that I'm live. Okay, so there were a couple things we talked about in the last video that were pretty important, and that was mainly the aortic, pharyngeal, aortic and pharyngeal arches, right? So the whole arches, clefts, pouches, all of that stuff, very significant because they're easy giveaways. Now, keep in mind that the aortic arch derivatives are very much related, right? Because you can see the arteries here. So these arteries are kind of what we're really talking about when we talk about the aortic arch derivatives, right? And it's really, each one is giving you some arteries, and that's kind of what we're talking about, right? So the first aortic arch gives you your maximal stuff, so maxillary artery, which is pretty much the same as your first pharyngeal arch, also giving you maxillary stuff, right, as well as many other things. The arches are huge, as you can see from this image right here, right? And remember, pharyngeal and branchial, same thing. So as you can tell, the arches are pretty big things, so they do give you a lot of stuff. The easiest thing were to memorize the pharyngeal cleft, which is also called the pharyngeal groove or the branchial groove, right? Cleft and groove are the same thing, of which only the first one really gave you something, and it was just the external auditory meatus. Okay, and if you remember the cap mnemonic, the cleft is ectoderm, so it's outside, and external auditory meatus should come to mind. The arches give you mesodermal and neural crest cell stuff, the pouches give you endodermal stuff, and we talked about all of that. This image is pretty significant. You will see different variations of this same picture, right? And this cervical sinus is pretty relevant because if this cervical sinus remains, right, if it doesn't go away, then you get the persistent cervical sinus issue, which is usually not pouching somewhere, not pouching, a cyst on your lateral neck, right? So that's something that has to be dealt with. But generally speaking, these clefts just disappear. So it's only the first one that gave you anything, and then everything we talked about in the video, in the last video, I found some pictures that I kind of went ahead and put into this page now, so it wasn't there in the last video. There are some muscles here that you might not know about, and then it's always nice to revise the tongue at this point, because when you looked at the tongue at the end of neuroembryology, you saw that the arches were significant here, right? So you can see the first two arches give you the anterior 2/3 of the tongue, the third and fourth arches give you the posterior 1/3 of the tongue, and the cranial nerves that were relevant there are pretty much relevant here too. So you can see how the first two arches gave you the anterior 2/3 of the tongue, and you have cranial nerve 5 and 7 that are important. So similarly, as you can see, the first pharyngeal arch is related to cranial nerve 5, second pharyngeal arch is related to cranial nerve 7. So the same relations are still being seen as well. And then these muscles are discussed, right? So there's the digastric, there's an anterior belly, it's the green muscles in this picture from Teach Me Anatomy. The first arch gives you the anterior belly of the digastric, and you do need to remember that because it's a silly little topic that you can get a very easy giveaway question on, right? They can just give you the anterior belly of the digastric and then ask you what, where it comes from, which arch it comes from. Excuse me. It's like really cold out today. Okay, so anterior belly of digastric is this one up here, posterior belly of digastric back there. Okay, those guys are both relevant actually for our arches, the first two. So you can see the second pharyngeal arch gives you the posterior belly of digastric, and the reason these are more testable than the others is because it doesn't fit the mnemonic we're using, right? Like this is everything with M, but this has nothing to do with an M. Tensor tympani, you have to remember. All right, and then the tensor veli palatini, both tensors also come from the first, and generally speaking, I would just say the first gives you all the ear stuff. There's only one ear thing that doesn't come from the first. So you remember how the second aortic arch was stapedial? The second pharyngeal arch is also stapedial, right? You have your stapedius here, as well as the stylohyoid, platysma, and then the posterior belly of the digastric. Okay, so that's the one that goes more horizontally. Okay, it's not coming down straight. Um, but that's generally it, right? Then you can also see the red mylohyoid, which comes from here, right? And then the blue one is geniohyoid. Okay, but that's not really relevant up to there. And then that was really it. The third and fourth pharyngeal arches had relations with the posterior one-third of the tongue, right? So you see how cranial nerve 9 is a big deal there. Cranial nerve 9 is related to the third. The further back portion was cranial nerve 10, and that's your fourth arch. Okay, fourth arch is cranial nerve 10, superior laryngeal branch. This image here shows you the lesser and greater horn. So the lesser horn is this yellow thing, and the greater horn of the hyoid is the back green one, right? So this is your hyoid. Right, and you can see the third pharyngeal arch actually gives you the greater horn of the hyoid, whereas the second pharyngeal arch gives you the lesser horn of the hyoid. Okay, everything from the fourth to sixth arches is generally just going to be stuff for the throat, right? So you have your arytenoids, cricoid, corniculate, cuneiform. We discussed all of this last time. The fifth makes no major developmental contributions, so never pick the fifth pharyngeal arch. And even when we were in the aortic arch, the fifth had nothing. Okay, so the aortic and pharyngeal arches do kind of go hand in hand. It's pretty easy to memorize, but as I said yesterday, it takes time, and you do have to invest an entire day really just looking at all of it and getting it down. We also talked about the pouches, and we stopped here. So I didn't talk about this yesterday, so we can get this continued now. So cleft lip and cleft palate. Now, this has been a topic that's even in newer NBMEs as well. Your cleft lip is kind of what they're showing you right here, right? And more than commonly, usually is on the left rather than the right. So the way they're showing you here. Failure of fusion of the maxillary and merged medial nasal processes. All right, so medial nasal processes, and it's very easy to remember it's medial nasal process because it's nasal, it's right by your nose, and it's in the middle, so medial, right? It's more towards the center, not lateral. So failed fusion of the maxillary. First of all, you also have to remember it's maxillary, it's your upper stuff, not mandibular. Because the reason you need to remember is because you get questions where you have to pick that as an answer choice. So you're going to pick the maxillary medial nasal process didn't fuse. That would be the correct answer for why someone has a cleft lip. Now, cleft palate is a failure of the fusion of the two lateral palatine shelves, or failure of fusion of lateral palatine shelf with the nasal septum, right? Or median palatine shelf, any of these. So there's many different answer choices here now for why someone might have a cleft palate like this, right? So now it's basically their lateral palates didn't fuse in the middle. So whichever answer choice most accurately and best describes that, you pick it. Cleft lip and cleft palate have distinct multifactorial etiologies but often occur together. No, it's like I'm a little concerned about my chronic cough, but I only really get this cough when I'm breathing really cold air. But thank you for asking. My cold is definitely over. Yeah, but I feel like I'm going to get something new now because it's just been really, really cold outside. Like, I bundle up when I step out and all that anyway, but I end up just freezing, and then I guess I'm just really sensitive sometimes. But I gotta make effort to keep myself better bundled up from here on, because I definitely don't want to get a cold again or anything like that. But my cough isn't exactly going away, which is really bothersome. Sometimes it feels like a dry cough, but most times it feels like I'm still sick or something. But I'm okay. Thank you for asking. The multifactorial thing is also a big part, right? So they'll ask you, like, they might give you a question or an image or any kind of presentation where someone has cleft lip or palate, and then they can ask you, like, what could be the genetic aspect of it, right? Or what could have caused it. And it's multifactorial, right? Multifactorial. And they often occur together. So if you do have a cleft lip, there's a pretty high chance you might have a cleft palate too. Now at the bottom here we had an embryology question, so let's take a look at it. This is from UWorld. It says, a newborn is taken to the neonatal intensive care unit after delivery due to respiratory distress. The neonate was born full term and there were no significant complications during pregnancy or delivery. Once the patient is stabilized, a detailed physical exam is performed. The neonate has an underdeveloped mandible and hypoplastic zygomatic bones. Genetic testing confirms a gene mutation that results in abnormal development of the first and second pharyngeal arches. Okay, so first and second pharyngeal arches. What structure is also likely abnormal in this patient? And then they give you a bunch of answer choices, right? So you have to remember all the derivatives for the first and second arch, as well as derivatives of the other arches, so you can cancel them out. And when you look at it, right, it's a cricoid cartilage. You have to remember where that comes from. Glossopharyngeal nerve, that was not related to this either. The greater horn of hyoid, also not relevant. Stapes is, right? Second is stapedial. And that was a very easy answer choice to pick. 72% of people got it right. Thyroid cartilage and vagus nerve. Now, when you're looking at these answer choices, you should be able to list in your mind where they come from. Right? So if you come back up here, right, all those things that are in the throat are 4 to 6 pharyngeal arches, including the cranial nerve 10, which is another answer choice. The greater horn of hyoid and glossopharyngeal nerve, those two things were related to a third pharyngeal arch. Okay, and then the only one they gave that was related to either one of these two arches was the stapes, right here. Right, so that's a very, very simple type of question to ask. It's very common. This is how it'll be on your step 1 as well. Right, they'll try to make up some kind of scenario, some kind of ICU thing, any kind of real clinical case, and then try to relate that to embryology, which you don't really need to know to treat that clinical case, but this is how tests are. So that's pretty much the end of like hardcore embryology. Now we're more so looking at clinical embryology. So this is everything that you need to know for genital embryology, right? So last time we were looking at genital stuff, we look at this picture right here, right? And Kaplan had a very similar image to this, kind of describing a lot of stuff. So I'm going to kind of go back to that right here, right? So right after the 4th week where the body folding was done, now you have this like, you know, semi-finished body form, right? You can see hands, legs. In the middle here, you have these blue areas, right? And the lighter blue area is your urogenital ridge. The dark blue area are your indifferent gonads, right? So your gonads kind of arise right there where your kidneys are going to be. So now from here, you can see that the yolk sac is giving your primordial germ cells. These primordial germ cells are actually going to be able to migrate into the abdomen and go into the gonadal ridge, right? And those germ cells will induce the medial mesoderm to become gonads. Right? So that's a very important embryological thing you need to remember just for test purposes, basically. And now we can just start looking at how the organs actually develop. So female is the default development, right? The mesonephric duct degenerates and the paramesonephric duct develops, okay? So in this image, they're showing you pretty much everything. Nothing has degenerated yet, so you have your indifferent gonad, the most medial thing. Next to your indifferent gonads are your mesonephros. And then further out from the mesonephros are the yellow paramesonephric duct. Right, so perfectly named paramesonephric is right next to the mesonephros. Your mesonephric duct, right, and the paramesonephric duct both go down into the urogenital sinus, right? And at this point, nothing has happened. This is all indifferent gonads. Now, depending on whether you have all of these things or none of them, you're going to get either the left side case scenario, which is the male development, or the right side case scenario, which is the female development. So the female development was default. No androgens are present. Then from here, in this gubernaculum, you can see the mesonephric, right, for men has degenerated, right? And now the indifferent gonad has become an ovary. And your paramesonephric duct is the guy that's, this yellow one is the guy that's now kind of connected right here as the oviduct, okay? And you have your uterus developing and all kinds of other stuff. For the male, you need a couple things. So if you have a Y chromosome, you're a male. And as a Y chromosome, you can make this SARY gene, SRY, which produces testes determining factor, TDF. Now, testes determining factor causes testes development, right? So you're not going to go with the default development anymore. Sertoli cells secrete Mullerian inhibiting factor, which is inhibiting the female stuff. Mullerian or mother inhibiting factor, MIF, is an anti-Mullerian hormone that suppresses development of the paramesonephric duct, right? So now you're going to get rid of the paramesonephric duct. So that's the yellow thing that's outlined, degenerated paramesonephric duct. And your mesonephros now gave the epididymis, right? And the vas deferens down here. Epididymis and vas deferens all came from the mesonephros, as you can see. Leydig cells secrete androgens that stimulate development of the mesonephric duct. And that's why that green mesonephric duct has remained. Whereas in the female, the yellow paramesonephric duct remained. All right. Now keep in mind that you can see the paramesonephric duct did give some part of the uterus, all right, but nothing for the vagina per se. It's just the uterus here. Right? Whereas the mesonephros and the mesonephric duct, that gave the epididymis and vas deferens, but nothing for the penis per se. Now, in the female, the paramesonephric or Mullerian duct develops into the female internal structures. So that includes your fallopian tubes, uterus, upper portion of the vagina. For males, the paramesonephric duct remains as an appendix testes. Okay, you can get some silly questions on this too. I think NBME had a really stupid appendix testes question where a guy was releasing some testosterone from it, and he shouldn't have been releasing that much testosterone, so they were wondering where it's coming from. It was so weird. Like, I suppose by sheer logic you could get it right, or if you've actually seen a case scenario where the appendix testis was actively doing something, then maybe you could get it right. I got that question wrong, and I was just like, why would you even ask a question related to something so rare and unnecessary? Alright, so anyway, keep in mind, right, the Mullerian duct does give you the upper portion of the vagina, and this is something that gets tested. The lower portion of the vagina comes from the urogenital sinus, right, urogenital sinus, and we're going to see that later on too. So this is also a nice time to go back and revise your renal embryology, because in your renal embryology you also had some of these similar structures giving you things. Now down here they mention Mullerian agenesis, which is obviously something you're going to get a question on. Mullerian agenesis may present as primary amenorrhea due to lack of a uterine development in females with fully developed secondary sexual characteristics because they have functional ovaries. Okay, so if you get a female presenting with good secondary sexual characteristics and she's developing just fine as a female, but has amenorrhea, which is usually the primary reason they come in, then you want to immediately think of Mullerian agenesis, because one of the many reasons you can have amenorrhea is because you might not even have a uterus. If you don't have a uterus, you're going to have primary amenorrhea, and that's it. All right. The other reason you can have amenorrhea is because of a hormonal imbalance, and if they gave you other things in the question, think of that, then you can go ahead and think of that. Right, but that's your Mullerian duct. Now, the Wolffian duct or mesonephric is the one that was for men. It develops into the male internal structures, right? But the prostate, although it's an internal structure, it has nothing to do with the Wolffian duct per se. So you get your seminal vesicles, epididymis, ejaculatory duct, and ductus deferens. The female remnant here is a Gartner duct. Right? These remnants should not be of major concern, but if you can memorize them, then great. But they really should not be of major concern. Now, the latter half of this page talks about sexual differentiation, and this is a nice thing right here, showing you the same stuff about the undifferentiated gonads, the same image, but now showing you with, the messaging that's happening. So on this side, now this is pretty important, the medulla and the cortex, okay? On the left, the men, right, you have the medulla, right, and there's SARI gene, which leads to more testes action, and because of the testes determining factor, and your testes have cells that release things. The Sertoli cells release Mullerian inhibiting factor that goes all the way down here and stops Mullerian duct formation. Right, so remember your Mullerian duct had given you fallopian tubes, uterus, and proximal vagina. All of that disappears, right, because you're making a man. The Leydig cells release testosterone, which first cause your Wolffian ducts to become internal male genitalia, and then through the activity of 5-alpha-reductase, testosterone becomes the more potent dihydrotestosterone, which helps form the external male genitalia, like the penis and the scrotum, plus the prostate. Okay, so this is where your prostate is coming from. You need DHT for that, and you can always remember that because finasteride, a 5-alpha-reductase inhibitor, is used to help people with BPH to get rid of their bigger prostate, right? So now here you can already see a case scenario where a patient who doesn't have 5-alpha-reductase, right? If you don't have 5-alpha-reductase, that's what they're showing here. If you don't have 5-alpha-reductase, then you get male internal genitalia, because this part is going to be fine, right? But ambiguous external genitalia until puberty, when more testosterone levels cause masculinization. Right, so the penis might not look so much like a penis. Now, I don't really know entirely how functionally good this is going to be, because it wasn't quote-unquote ambiguous external genitalia until puberty. But, like, you're not supposed to have an ambiguous male genitalia in the first place, so it might not be so functional. But generally speaking, this guy should be able to get a woman pregnant. So it shouldn't be a major concern in that aspect, right? So he's going to be okay. The first one is a little bit of a bigger problem. So now, if you have an absence of Sertoli cells, right? If you don't make Sertoli cells from some kind of weird issue, then remember Sertoli cells made the Mullerian inhibiting factor to stop the formation of internal female genitalia. Absence of Sertoli cells or a lack of Mullerian inhibiting factor develops both male and female internal genitalia while you're having DHT causing you to make male external genitalia. So not having MIF is a bigger problem, right? Number one is definitely a much bigger problem. You don't want to be born with fallopian tubes, a uterus, and a proximal vagina. That's really going to mess things up. The only thing that has no, real effects, I guess, is that there's no messing up this part, the default part, right? So in this default part, if you're XX and you don't have a SAR gene and you don't make testes determining factor, you're straight up just gonna become ovaries, and the ovaries are gonna make estradiol, and that's gonna cause you to have external female genitalia, right? So now these kinds of things, this diagram is pretty straightforward, and you do need to memorize this outline and really get this down in your mind. You will have questions on it. You will have very simple questions on it, and it's purely memorization. The questions in reproductive are almost always something about a man or a woman presenting with either physical structures that don't belong there or aren't correct for their gender, or some kind of hormonal imbalance like amenorrhea, um, and you have to, or a male with infertility issues. That's another thing, right? And all of these are different case scenarios, so you have to figure out what's the most common one and what could have caused it. So let's take a look at this question. This is from UWorld. So a 32-year-old woman, G2P1, with an uncomplicated prenatal course, delivered a 9-pound newborn at 39 weeks gestation via spontaneous vaginal delivery. ABGAR scores were 8 and 10 at 1 and 5 minutes, respectively, which is great. Further evaluation in the newborn nursery shows abnormal sexual differentiation of the new baby. Karyotype analysis shows 46XY, which confirms it is a male. Biopsy of gonadal tissue shows a lack of Sertoli cells, but normal latex cells, right? So ladies love testosterone. So latex cell makes testosterone, in case you're having trouble memorizing that. Sertoli cells are the ones that stop female development, right? So you're not going to be able to stop the female development of internal female genitalia, right? Remember that ovaries or testes, right? So since you already made testes, don't pick an answer choice that says you're going to have ovaries, right? Ovaries aren't going to form because you already made testes. In fact, he already made testes because he's making testosterone. And they told you that the biopsy has normal latex cells, right? So he definitely made testes. Now the only mistake can be that he's not going to get rid of internal female genitalia. What phenotype will most likely be present? Well, he's going to have female and male internal genitalia, right? So both female and male internal genitalia, but only male external, because you can't have both external. Not in this case scenario, right? So with male external testes contain both Sertoli and latex cells, right? Sertoli cells, so for him though, he doesn't have Sertoli cells, but testes contain both Sertoli and latex cells. Sertoli cells suppress female internal reproductive organs using MIF. Latex cells secrete testosterone, which again, through the help of reproductase, brings up all of these things. Okay, so very important to make sure you can, really get this stuff down. This is the first real interaction you have with sexual differentiation. Okay, first real interaction. It's all from the same stuff. If you have a problem in any of these things, these are the issues people will present with. And generally speaking, it's always a male presenting with some kind of issue, not really a female. Because if you did have two X chromosomes and you're a female, you simply just go with the default development and everything is going to be fine, right? Default development, nothing needs to be changed, nothing needs to be inhibited, no inhibitors are necessary, so everything works out fine. You just get a female with external and internal female genitalia. But if you're a male, now there's a couple things you can have, and these are the two most common mistakes. Either your Sertoli cells are not working, or you don't make Mullerian inhibiting factor for some reason, or your follow-up reductase is not working, and all of those are different kinds of issues. So that's really it for that. Okay, then you have uterine anomalies, and all of these are Not exactly the rarest thing on earth. You can see these, and if you're doing OB-GYN, if that's what you're looking to do, OB-gynecology, then at some point you will definitely start seeing a lot of these more commonly. Now, the normal uterus looks like this, okay? Then you have some of these that can be pretty problematic, especially because the uterus's job is just maintaining pregnancy. So it has to be nice and spacious in there, and it has to function correctly. The septate uterus, which looks like this, is a common anomaly versus the normal uterus. Incomplete resorption of the septum up here leads to decreased fertility and early miscarriage or pregnancy loss. And the only way to treat this is to get rid of this. Okay, as you can see, that little septum is pretty much occupying where the baby would grow. So that's no good. A bicornuate uterus is where the septum kind of came in. Okay, incomplete fusion of the Mullerian ducts is why you get this. Okay, increased risk of complicated pregnancy and early pregnancy loss, malpresentation, or prematurity. Because again, there's just isn't enough space in here. Right, just not enough space in here for a baby to develop. The last one is uterus didelphys, and this one is pretty rare, but this is a complete failure of fusion, leading to a double uterus, cervix, and vagina. Pregnancy is possible, and heck, double pregnancy is possible, right? If at some point you release an egg from both sides, and there is an egg on both sides, you can actually fertilize both eggs. Right? So double pregnancy is possible here as well. And now at the bottom, you're seeing these images where they're using some kind of contrast, right? NBME had a very interesting question where they used these same images, but then they picked on something completely ridiculous. They weren't really trying to pick on the topic of uterine anomalies, but they actually wanted you to know a little more about the way this contrast works and how you're supposed to deduce what it means. So let's take a look at this URO question first so we can actually understand uterine anomalies, which is the more important thing. Then I'll talk to you a little about the NBME drama. So a 25-year-old woman, G4P0, comes to the office for evaluation of recurrent pregnancy loss. She has had 4 second trimester losses with the same partner. The patient has menstrual cycles approximately 28 days with light bleeding for 2 to 3 days. Her past medical history is significant for left renal agenesis. Family history is negative for pregnancy loss. Lab studies are negative for anti-cardiolipin antibodies and lupus anticoagulant, right? And that's significant because those lab studies were pretty much checking to see if this patient had antiphospholipid syndrome, where you do get recurrent pregnancy losses. Results of the patient's hysterosalpingogram are shown and resembles images or image C, right? So they did the hysterosalpingogram and it resembles image C. Okay, so this image was given in this URL question. A pelvic MRI is ordered and shows an abnormal contour to the uterine fundus. Failure of which process is the most likely underlying mechanism of her issue? And the answer was lateral fusion of paramesonephric ducts or Mullerian ducts. Failure of their fusion led to this. And very easy answer. Now, one of the reasons I chose this question was because it made a really interesting point. You saw in the question, they told you that her past medical history is significant for left renal agenesis. Okay, so they then explain in the explanation that this is another name for Mullerian duct. Developing of the paramesonephric and mesonephric ducts are closely linked, so uterine anomalies often coexist with renal anomalies, like in this patient. Failed lateral fusion leads to bicornuate uterus. Right? So if you do have a patient who has some kind of renal anomalies, it is very much likely that they also might have uterine anomalies. So keep that in mind. That can be a pretty important giveaway. And just for a quick revision, we can go back and take a look at that. So right before reproductive, we had renal embryology. And in renal embryology, you could see, again, the pronephros disappears. You have your mesonephros and you have your metanephros, right? And how do you make your kidney? Well, the mesonephros, with its mesonephric duct, functions briefly before degenerating, right? The mesonephric duct is only there functioning for like a very tiny period of time. It's not actually significant. The metanephros is what actually gives you the definitive kidney, right? And here they continue to break it down for you. So your ureteric bud, which is also called the metanephric diverticulum, all right, gives you the entire what do you call it? the collecting system, right? So your ureter, pelvises, calyces, and collecting duct. That's your entire collecting system. The metanephric mesenchyme, right, or blastema, here, this thing gives you your entire blood supply, right, all the way from the glomerulus all the way to the DCT, right? So this is the stuff we've kind of already reviewed, and there was a lot of interaction here that was very important, and this is the embryology that we're kind of talking about right now too. All right, so again, right here, when we were looking at it in this image, right, same exact stuff. You have your mesonephric duct and paramesonephric duct. And of course, the mesonephric one is the one that's kind of related to the kidney. All right, but since they're all in the same area, the paramesonephric duct also often has a lot to do with it. If your mesonephric duct is missing, you might be missing the paramesonephric duct too, which then leads to a bicornuate uterus because you're not going to have a fusion. Right, there is only one paramesonephric duct. You're going to have no fusion, and you can end up with a bicornuate uterus. This image kind of shows you what the genital homologs are. You know, obviously study it, make sure you understand it. It's nicely color-coded and all that stuff, but it's not exactly that significant. It's not really that significant. You can get silly questions where they'll be like, you know, a male came in and they have an issue with their Cowper gland, right, the bulbourethral gland. A similar issue in a female would be a lack of which gland, and it would just be the Bartholin gland. So, you know, they can give you questions where they kind of want you to compare the two, but it's not that high yield. It's really not that significant either. You can study it a little bit. You might be able to memorize it just fine, but I think what I would focus on is to remember that the labia majora is very much like the male scrotum, right? So labia majora and male scrotum, very similar pairing right there. They both come from the labioscrotal swelling, right? But that's generally it. Everything else, you know, labia minora, urogenital fold, is very much like the ventral shaft of the penis. And then, you know, just you could take a look at it. It's not so bad. The sinuses just give you glands, and then the tubercles give you your actual clitoris and glans penis. So it's not so bad, but not the most high yield thing to know. The last thing you look at in reproductive embryology are your congenital penile abnormalities and then the descent of the testes and ovaries. So for penile abnormalities, you can definitely get an easy question on hypospadias versus epispadias, right? So hypo is below the penis and epi is above the penis, right? And it's just an extra opening or an opening that isn't in the correct place. So this basically means that you might not actually have an opening at the face of the penis. So the only opening is this one. Okay, it's an abnormal opening of the penile urethra on ventral surface of the penis due to failure of urethral folds to fuse. So this bottom surface is the ventral. The back of your hand is your dorsum. So the back of the penis is your dorsal surface. Okay. So ventral opening is hypospadias. Hypospadias is more common than epispadias and is associated with inguinal hernias, cryptorchidism, and cord D, which is a downward or upward bending of the penis. All right. So this is definitely more common. Epispadias, you have to remember the other E thing, extrophy. Right. Epispadias is an abnormal opening of the penile urethra on the dorsal surface of the penis due to faulty positioning of the genital tubercle. Right, and these are all answer choices that are something you can, you know, really get confused about when you're finally sitting there to look at a question, because you might see the question might be about hypospadias, then you have, you know, the question is going to say why did it occur, and you'll have both answer choices: failure of urethral fold to fuse, faulty positioning of genital tubercle, and at that moment you won't remember. You're looking at it right now as a whole different presentation and you're good to go. But as soon as you see it on the test with, you know, the answer choices and all that, it all becomes such a blur, and then you get it wrong. Or you guess and you move on very, you know, with the lack of confidence, basically. So you want to make sure that you definitely remember it. Keep in mind that the urethra folds, you know, from up to down. So if it didn't fold correctly at the bottom, it's not going to close. Right? Whereas the genital tubercle, if it's positioned incorrectly, it just opens up upwards. How you're going to memorize that is completely up to you. I haven't really come up with the memorization technique for this per se, but it's always been pretty easy, if anything. All right. Extrophy of the bladder is associated with epispadia, so keep that in mind too. We saw what extrophy of the bladder looks like in GIT. And that's really it. So just remember these two answer choices, right? And most importantly, if you can just remember one, then you should know the other. So most importantly, remember the one that's more common. Hypospadias is due to a failure of the urethral fold to fuse. It fuses at the bottom and it didn't fold and fuse correctly. The last thing, descent of testes and ovaries. So you have your gubernaculum and your processus vaginalis. Gubernaculum. Description: bound of fibrous tissue. The male remnant actually anchors the testes within the scrotum, and the female remnant is your ovarian ligament and the round ligament of the uterus. Keep in mind that the round ligament of the uterus can cause normal pain during pregnancy. Right, so that round ligament is pretty significant, and they could ask you, where it came from. It came from the gubernaculum. Processus vaginalis causes evagination of the peritoneum. It forms the tunica vaginalis in males and is obliterated in females, so it's not that significant. But the gubernaculum is definitely pretty significant. Alright, so failure of processus vaginalis to close can lead to an indirect inguinal hernia, and that's where you first heard of the processus vaginalis when we were looking at inguinal hernias. And we also mentioned round ligament of the uterus earlier as well, and we're going to hear more about it here now as we go into reproductive anatomy, because the round ligament can cause normal pain in early pregnancy. So that's your embryology. In the next video, we're going to continue on into some of the more hardcore stuff that you can get really annoying questions on, reproductive anatomy.